speaking today on HER2 positive metastatic breast cancer. Here are my disclosures. So HER2 positive breast cancer, as we know, is defined by the increased expression of the HER2 protein or increased HER2 gene copies. It comprises approximately 15 to 20% of all breast cancers. And historically, in the absence of HER2-directed therapies, the prognosis is poor. And here are data sets prior to the development of HER2-directed therapies showing that compared to other intrinsic subtypes, ERBB2 positive subtypes have poor outcomes, including distant metastases as well as survival. And of course, that's significantly changed since the development of HER2-directed therapies, the first and most widely used of which is trastuzumab. Trastuzumab was first approved in the US in 1998, and it is a monoclonal HER2 antibody that inhibits downstream signaling as well as engages the immune system for antibody-dependent cell cytotoxicity. The initial trials of trastuzumab in the early stage setting for breast cancer across the board demonstrated an improvement in disease-free survival, resulting in the widespread use of trastuzumab. But what I like to highlight from these trials is despite all of the success that we had early on with trastuzumab, if you look at the 10-year recurrence data from these initial adjuvant studies of trastuzumab, there's still a recurrence rate of 25 to 30%. So a significant room for improvement beyond trastuzumab. And what we've seen as we followed HER2 positive metastatic disease over years is that we continue to have improvement in long-term survival, despite having decades now of having trastuzumab widely available for our patients. And this is due largely to increased recognition of HER2 positive disease early in diagnosis, but also due to the ongoing innovation in this space. So coming from 1998 to 2022 today, we have a significantly increased number of HER2-directed therapies. Here in the US, we have 8 currently FDA-approved agents available for our patients. So we'll spend the rest of the talk today talking about the innovation in this space and focusing largely on the HER2 antibody drug conjugates. I'm sorry, did I miss something? Okay. So despite all our innovation, our first-line treatment for HER2-positive metastatic disease today remains the combination of chemotherapy, trastuzumab, and pertuzumab.
I'll put some stuff's finished drying and the rest is in the wash and it needs to go to the dryer.
Remind everyone to
Is any of
please
it, could you do that?
your
Because you might know what
microphone.
doesn't need to be dried.
Yeah, I'll do that.
Maureen.
Okay, there we go. So our first-line treatment still remains the combination of docetaxel chemotherapy, trastuzumab, and pertuzumab on the basis of the Cleopatra studies. This is a study that enrolled previously untreated metastatic patients, randomized them to receive docetaxel and trastuzumab with placebo or pertuzumab. And in the landmark analysis of this study, we see that the overall survival with the triplet combination is nearly approaching 5 years, 57.1 months, significantly improved compared to docetaxel and trastuzumab alone. And what's really notable from these curves is this tail of the curve, where we know there's a number of patients who remain on maintenance, Herceptin and Perjeta long-term and have ongoing disease response. Unclear if these patients have been cured of their disease. In the second line setting, antibody drug conjugates have really sort of taken over this space. So antibody drug conjugates facilitate the delivery of highly potent cytotoxic molecules directly to tumor cells expressing unique antigens. And as a result, they increase the therapeutic window of cytotoxic agents. Antibody drug conjugates have sort of 3 primary components, which is the antibody itself, the linker, which can have various properties, and then the payload that they bring along. So TDM1 or trastuzumab emtansine was the first antibody drug conjugate to be widely used in the second line setting. So this is an antibody drug conjugate that has an anti-microtubule agent as its payload. its drug to antibody ratio is about 3.5 to 1. So that's the number of payloads that each antibody carries. The linker in the case of TDM1 is non-cleavable, which means that the antibody drug in this case has to be completely degraded in the lysosome for the payload to be released. And the payload in this case does not have a bystander anti-tumor effect, meaning it cannot permeate through the membrane into neighboring cells. So TDM1 was first approved in the second-line setting on the basis of the Emilia study. This was a study that compared TDM1 to the combination of lapatinib and capecitabine and reported a statistically significant improvement in both median progression-free and overall survival. And on the basis of this data, for many, many years, TDM1 was our standard second-line agent for HER2-positive metastatic disease. But in recent years, that's changed drastically with the development of trastuzumab deruxtecan. So trastuzumab deruxtecan is another antibody drug conjugate, and it's distinct from TDM1 in several ways. First of all, the payload here is a topoisomerase 1 inhibitor. It has a higher antibody to drug ratio, drug to antibody ratio, 8 to 1. And in this case, the linker is cleavable, meaning it does not have to be completely degraded in the lysosome. It can be cleaved within the tumor cells. And the payload here does have bystander tumor effect, meaning it can permeate into neighboring cells and have activity there. So as a result, you can see that there's more drug delivered. The drug is cleaved from the antibody faster, and it can enter into neighboring cells, increasing the overall potency of this agent. So TDXD was first assessed in the DESTINY-Breast01 study. So this was a study that looked at heavily pretreated patients with HER2-positive metastatic disease. They had received a median of 6 prior lines of therapy for metastatic disease, with 100% of patients having received prior TDM1. Approximately 60% of patients had visceral disease on this study. And despite these features, there was a confirmed response rate of 62% with TDXD in this study. And you could see this waterfall plot. It's very impressive with this agent. Based on the success of this study, the DESTINY-Breast03 study evaluated TDXD versus TDM1 in the second-line setting. So this was patients with metastatic HER2-positive disease who had previously been treated with trastuzumab taxane in the metastatic advanced setting. In this study, patients could have clinically stable treated brain metastases, but not untreated brain disease at the time of study entry. Primary endpoint was median progression-free survival. And here's the data for the median progression-free survival from this study. So TDXD resulted in a statistically significant improvement in median progression-free survival with a hazard ratio of 0.28. So very impressive results here with a very notable improvement in median progression-free survival. The 12-month PFS rate was 75.8% in the TDXD treated patients compared to 34.1% in the TDM1 treated patients. So based on this study, TDXD has now become our preferred second-line agent for patients with HER2-positive metastatic disease. Survival from this study is currently pending, but has started to show a strong trend favoring TDXD. Here is the subset analysis looking at PFS in with TDXD, and you can see that essentially in all subsets, there is a notable and statistically significant improvement in median PFS with TDXD over TDM1. Here's the waterfall plot from this study looking at TDXD. You can see, again, very impressive with a number of patients achieving complete response, 16.1% of patients, and an additional 63.6% of patients achieving partial response for a confirmed response rate of nearly 80% in this study. So again, very impressive results from this study. But what's really notable about comparing these two agents is the toxicity profiles of these agents. So many of us have had a lot of experience with TDM1 for a number of years. And relatively speaking, TDM1 has been a fairly well-tolerated agent. And when we compare the toxicity profiles of TDXD versus TDM1, we do see an increase in both all-grade and grade 3 toxicity events with TDXD. So this includes cytopenias. We see increased cytopenias as well as grade 3 cytopenias with TDXD compared to TDM1. It does include GI side effects. So we again see increase in all grade and grade 3 GI side effects with TDXD compared to TDM1. And notably also includes alopecia. So we see higher incidence of alopecia in TDXD treated patients compared to TDM1. Interestingly though, just recently at ESMO Breast, just a few weeks ago, the quality of life data with TDX from the study was presented. And interestingly, the quality of life with TDXD is maintained similar to that of TDM1. And in fact, some of the variables in terms of quality of life assessments were improved with TDXD, suggesting that despite this increase in some side effects, TDXD is really well tolerated, and perhaps the overall improvement in disease status with this agent lends itself to an improvement in quality of life as a whole. Of course, there's the adverse event that's probably the most talked about with TDXD, and that is interstitial lung disease, pneumonitis. So early on in the Destiny Breast 01 study, we did see, very notable ILD pneumonitis events, including grade 5 events. So that was definitely a big topic of interest as the Destiny Breast 03 data was presented. And fortunately, as this agent moved into earlier lines of therapy, we did not see grade 4, grade 5 events on this study. We did see 2 grade 3 events, but the majority of ILD pneumonitis events in this study were grade 1, grade 2 mild. And so what is the reason for this? It might be that as this agent moves into earlier lines of treatment, the patients are healthier and better able to tolerate the agent, but it's probably also partially due to increased recognition of this toxicity and better management. So here is data presented looking at ILD events with TDXD across all clinical trials of TDXD, not just limited to breast cancer patients, but all clinical trials of the agent. And you can see early on, in the early years that this agent was in clinical trials, we saw a high number of ILD events, including grade 5 events across multiple studies. But at the end of 2019, AstraZeneca released an update in toxicity management guidelines for ILD. And you can see with that, starting in 2020, we see a decrease in the incidence of ILD events, particularly in grade 4, grade 5 events. Suggesting that as we become more aware of this potential toxicity and learn how to manage it better, that perhaps we see decreased incidence of at least high-grade events. So here are the current sort of guidelines put together by AstraZeneca in terms of monitoring for ILD as well as treating ILD in these patients. And so step one for anyone that receives TDXD is to really be mindful of monitoring very closely for symptoms that might suggest that the patient has experienced pneumonitis or ILD, such as dyspnea, cough, or fever. And if ILDs are all suspected, the first step is really to interrupt drug. At that point, further evaluation can be undertaken, whether it's CT, pulmonary consultation, PFTs, or more invasive workup. And subsequent to that, we can talk about management with steroids. But really, the first step that we all need to consider is really keeping a close eye, counseling our patients, and interrupting the drug if it is all suspected, and then taking on further workup and management. So talking about management, how should we treat the patients in whom ILD is suspected? So for patients who have grade 1, in all of these patients, we've interrupted drug already. But in grade 1 patients, we can consider monitoring and closely following these patients. We can consider starting steroids in these patients, at least 0.5 milligrams per kilogram per day of prednisone or equivalent, followed by gradual taper. And if we see worsening symptoms or imaging findings, then of course we need to escalate into more aggressive treatment strategies. For patients with grade 2 ILD, these patients, we definitely want to start steroids, at least 1 mg per kg per day of prednisone for at least 14 days, followed by gradual taper. And we want to monitor the symptoms closely, re-image, probably get pulmonary consultation involved. And if there's no improvement, then of course we can escalate to grade 3 or 4. Grade 3 or 4 patients, we want to hospitalize, empirically initiate high dose methylprednisone IV treatment, followed by a slow taper. The current guidelines are for patients with grade 1 ILD, we can consider reinitiation of TDXD. So if they're monitored or treated with steroids with a gradual taper and they improve, we can consider restarting treatment in these patients, but anyone with grade 2, grade 3, grade 4 ILD, drugs should be permanently discontinued in these patients. So based on the success of the DESTINY-Breast03 study, the TDXD is being evaluated in the first-line setting for patients with HER2-positive metastatic disease in the DESTINY-Breast09 study. So this is a study in which patients with no prior therapy for metastatic disease will be enrolled. Patients will be randomized to receive TDXD monotherapy, TDXD plus pertuzumab, or our current standard of taxane plus HP in the frontline setting. So it'll be interesting to see, as TDXD has significantly disrupted our treatment paradigm that had existed for many years, if it will continue to do so in the first line setting as well. We'll talk briefly about some of the other agents that have become approved in this space in recent years. So one other notable agent is tucatinib. Tucatinib is a HER2 tyrosine kinase inhibitor. These are agents that inhibit the downstream signaling of the HER2 molecule. And what's unique about tucatinib compared to other agents available in this space is that it is highly selective for HER2 with limited inhibition of other members of the HER family, as opposed to lapatinib and neratinib, both of which also have significant inhibition of EGFR, resulting in the increased toxicity seen with these agents. So because of its very specific HER2 inhibition, tucatinib is a much better tolerated agent compared to others. What's notable about these HER2 tyrosine kinase inhibitors is that they have that they're able to penetrate the CNS. This is a very elegant study looking at CSF in patients treated with tucatinib, and you can see that over time, tucatinib is present in fairly stable concentration in the CSF after treatment. And even when we compare the ratio of CSF to plasma, we see that it's relatively stably present in the CSF, really highlighting that it does have CNS penetration and can be effective in the management of CNS disease. So HER2CLIMB was the study that led to the approval of tucatinib. This was a study that looked at tucatinib, trastuzumab plus capecitabine versus placebo trastuzumab and capecitabine. It enrolled patients with HER2-positive metastatic disease who had previously been treated with trastuzumab, pertuzumab, and T-DM1. So it was really sort of designed in the third-line setting and beyond. And what was really notable about this study is, for the first time in a randomized phase 3 study setting, we could enroll patients that had untreated brain metastases. So this included patients who had new brain metastases that had not been treated, or patients who had brain metastases that had previously been treated and were progressing. As long as patients weren't symptomatic from their CNS disease, they could enroll on study. So overall, the study reported a statistically significant improvement in both median progression-free and overall survival with the addition of tucatinib to trastuzumab and capecitabine, resulting in the FDA approval here in the US of the agent in the triplet combination. But looking specifically at the active brain mets patients, again, these are patients with untreated or previously treated and progressing disease. What we see is that the triplet resulted in a statistically significant improvement in CNS response. And looking at outcomes in those patients, we see significant improvement in both CNS median progression-free survival from 4.1 to 9.5 months, as well as overall survival in patients with progressive brain mets from 11.6 to 20.7 months. And so this is very notable because for the first time, we have a systemic therapy option for active CNS disease that results in improved CNS response, improved CNS median progression-free survival, and improved overall survival in these patients. And what's really interesting to me beyond that data is this very elegant analysis of looking at new CNS lesions. And so this is very relevant not only for the treatment of active CNS disease, but also for the prevention of new CNS disease. And we see a statistically significant improvement in new CNS lesion-free survival in tucatinib-treated patients too, suggesting that there's really rationale for using these agents even in patients who don't have active CNS disease in terms of preventing new CNS disease from developing. Another agent that has received recent FDA approval is margetuximab. So margetuximab is a novel HER2 monoclonal antibody with an engineered Fc domain. So the Fc domain, again, is the domain that binds to the immune cells, and this Fc domain has been engineered to have increased affinity for the activating domain CD16A. And what's important about CD16A is that a large proportion of the population has low binding genotypes of CD16A, so that's the F genotype. So 40% are homozygous for low binding and 40 to 45% are heterozygous for low binding. And these are specifically the patients that might benefit from the Fc engineering of margetuximab. And so the SOPHIA study was a phase 3 study that looked at margetuximab in patients who had received at least 2 prior HER2-directed therapies in the metastatic setting. And stable brain metastases were okay on the study. Patients were randomized to receive either margetuximab or trastuzumab in combination with chemotherapy. And primary endpoints included both median progression-free and overall survival. And here are the results from the SOPHIA studies. We can see overall, there was a very modest improvement in median progression-free survival from 4.4 to 5.7 months with a hazard ratio of 0.71. But what's more interesting is looking at the patients with F allele. So here is a pre-specified analysis of overall survival in homozygotes for the F allele. And here we see a statistically, borderline statistically significant improvement in overall survival from 19.2 to 23.6 months. So definitely more relevant in the F allele carriers or homozygotes. What's important is, should we be doing testing to identify these patients before we think about margetuximab treatment? And in fact, the company is working to improve access to allele testing to better identify patients who might benefit from margetuximab therapy. So based on this, I'll put up this slide presented by Shanu Modi at ESMO in 2021, looking at our current approach to patients with HER2-positive metastatic breast cancer. So as of today in 2022, our preferred first-line therapy remains the combination of taxane, trastuzumab, and pertuzumab. In the second-line setting, trastuzumab deruxtecan has really taken over this space. But I guess we can put in the caveat for patients who do have active CNS disease, given the established survival benefit in patients with active CNS disease, we can consider the combination of tucatinib, trastuzumab, and capecitabine in this space. Though, as we'll talk about later in this talk, there is growing data that agents like trastuzumab deruxtecan may have significant benefit in the management of CNS disease. So it's unclear if this treatment paradigm will change over time. In the third line and beyond, we sort of circle back to using agents that we haven't used. So if patients have received trastuzumab deruxtecan, then tucatinib remains an option for those patients. And otherwise, we fall back to some of our other therapies, such as TDM1, using margetuximab and chemotherapy, or other combinations of HER2 therapies and chemotherapy in our patients. There is, like we've mentioned, significant innovation ongoing in the development of new HER2-directed therapies. I'll just kind of mention a few ADCs that have been reported or are on the horizon. So recently we saw data from SYD985 or trastuzumab deocarmazine, which is a novel ADC. There were high hopes for this ADC from some of its earlier settings where we had seen very impressive response rates. This was another ADC that has a tumor permeable payload with bystander effect and a protease cleavable linker similar to TDXD. However, in the phase 3 study, TULIP study, where SYD985 was compared to treatment of physician's choice, we really saw modest benefit with this agent, an improvement in median progression-free survival from 4.9 to 7 months, and no statistically significant improvement in overall survival, sort of dampening the excitement behind this agent. There was also significant ocular toxicity seen in this study, with many patients experiencing some ocular symptoms. And so again, the excitement behind this agent is really dampened. But there are many ADCs that are now in development, and we wait to see if how those are going to perform. I'll just comment on ARX788, which has shown really exciting data in early studies. So this is a antibody drug conjugate with a tubulin inhibitor payload. And it's been engineered to have a highly stable chemistry, to have very minimal premature payload detachment. So the hope is that it will be very efficacious with minimal toxicity. And here's the phase 1 data in heavily pretreated HER2-positive metastatic patients, 6 median prior lines of therapy. We saw no dose-limiting toxicities with this agent, and the response rate was approaching 70% in this heavily pretreated group. So we wait to see how this agent will do in later studies, and if it'll disrupt our treatment paradigm in any way. So with that, I put together a patient case that we can talk through and work through. So I have JM. JM is a 62-year-old female. She presents initially with a palpable left breast mass. She has a mammogram that shows a 2.5 centimeter spiculated mass in the left upper outer quadrant, and an axillary ultrasound that shows a suspicious axillary node. Biopsy of the primary breast mass shows high-grade invasive ductal carcinoma that is ER 0%, PR 0%, and HER2 3+. An axillary biopsy confirms metastatic adenocarcinoma. She receives neoadjuvant TCHP ×6, and then undergoes lumpectomy and sentinel lymph node biopsy. On pathology, she's found to have a 1.2 centimeter residual high-grade invasive ductal carcinoma with negative lymph nodes. Based on the residual disease, adjuvant TDM1 is planned. But shortly after surgery, she starts to complain of right hip pain. And she undergoes imaging, which shows a large destructive lesion of the right hip and 2 suspicious liver lesions. Liver biopsy confirms metastatic breast cancer that's, again, HER2 positive and ER/PR negative. So what treatment would you recommend for JM at this point? Any takers?
So you may or may not know, Reva, that in Ontario, there's some very sort of strict guidelines with respect to treatment choices, and we don't have standard access to TDXD yet.
I see.
In the second line setting. But given that her disease progressed pretty quickly after THP, we would go here in Ontario to go to TDM1 as the standard until we get access to TDXD.
I apologize. I did not realize that. Okay. So, and is that likely to change in the near future?
I certainly hope so.
Okay.
Yeah, we're waiting for some funding decisions.
I see. Okay. Okay. So we'll pretend that you're in the US for the next 10 minutes and that you do treat this patient with, so I figured we would want to do some palliative radiation to that right hip given the destructive lesion, and we start systemic therapy with TDXD. And on her first restaging, she has great response. Her liver lesions are no longer visualized. Her hip lesion is more sclerotic. But she is noted to have some interstitial findings on her CT, some interstitial thickening, as well as brown glass opacities on the CT of her chest, though she denies any new symptoms, including shortness of breath, cough, fever. What would you recommend at this point based on some of the TDXD toxicity management data?
I guess I'm the one answering here. I wasn't expecting a quiz during the round. No, it's okay. But of course, you would have a high suspicion for ILD, right? Pneumonitis.
Right. So I was trying to get to sort of, I would consider this grade 1. She's completely asymptomatic. It's just sort of incidentally found on imaging. And so based on grade 1, as we talked about, we really recommend holding TDXD as soon as ILD is suspected. I don't think steroids are really sort of mandatory in this case. I think you could consider monitoring this patient given that she's completely asymptomatic, or if you're truly worried, I don't think it's wrong to initiate steroids. In this case, we could do, a lower dose, 0.5 mg per kg per day, and gradually taper. And of course, we would want to repeat the imaging to assure that we're seeing improvement. So let's say a high-res CT is reported 4 weeks later and fortunately shows resolution of the interstitial findings. And so in a case of grade 1 ILD, we could really consider re-challenging this patient. Anyone with grade 2 or higher findings, we would recommend permanently discontinuing TDXD. But given that her disease was grade 1 and responded fairly quickly to steroids, could certainly consider reinitiating TDXD in this case. But in this case, just to keep the story going, I sort of said that after 2 cycles, let's say she complains now of some symptoms. She's now got a cough and she's having some progressive dyspnea on exertion. At that point, of course, we would want to repeat the chest imaging. And in this case, the chest imaging again now shows interstitial findings. And so now we're thinking, she has grade 2 ILD. So in this case, like we talked about, we would permanently discontinue drug. And in this case, we would really mandate some steroids for management. And given that she responded so quickly to steroids in someone like this in the past, of course, we would probably be quick to initiate steroids again. But for grade 2 here, we would want to initiate at least 1 mg per kg per day for at least 14 days prior to a gradual taper, and monitor closely. And then unfortunately, we would have to think about alternative systemic therapy for this patient.
So Reva, I guess you intended to make it a bit interactive in terms of the case. Maybe I'll ask a question here if that's okay. How often are you guys monitoring for ILD? How often are you imaging? Because on trial, Destiny Breast 3 was pretty frequent, and we're deciding amongst our group, how often are we really going to do it from a practical standpoint off trial? So what do you do at Cedars-Sinai?
So and in line with the overall management guidelines that have sort of been released, we aren't doing any special monitoring. We heavily counsel the patients that this is something that we see with this agent. So if you experience any shortness of breath or cough, please call us immediately. But in the absence of that, we're doing our regular restaging every 3 months. I'm not modifying the restaging to do high-res CTs in these patients. It's really sort of standard restaging. Now, if they start to complain of symptoms at all, definitely need to act quickly. I mean, it can be really challenging because a lot of patients will get fatigued from treatment. And as a result of that, they have some shortness of breath, and that's not necessarily ILD. But I think if it's suspected at all, we need to be aggressive about it. I have made good friends with a pulmonologist since this and some of the CDK inhibitors and more agents are causing ILD in our patients. I do refer early to pulmonary if I suspect it. I think getting things like PFTs early and high-res CT early if it's suspected, so that we can act appropriately is really important. And I am quick to start steroids if I suspect it at all.
That's very helpful. Thank you. Yeah, we've engaged our pulmonologists locally as well as we anticipate more access to this drug.
Yeah. It's just in the last few years, just with increasing drugs that are causing ILD, I think it's become more common to refer early, and it's important to have that clinical partner. So. Okay, so with that, I'll sort of take a moment and talk about the growing indication of antibody drug conjugates, specifically T-DXd, beyond what we classically considered HER2 positive disease. So as we know, expression of HER2 is a continuum. And today what we call HER2 positive is patients that have 3+ expression of HER2 or 2+ expression with increased amplification of the DNA. But we know that patients with HER2 1+ or HER2 2+ who are negative by FISH still have some expression of the HER2 protein. And as we develop more potent agents that target HER2, there may be a role for treating these low expressors with HER2-directed therapies. And so we're now talking specifically about what we call HER2 low disease. So these are patients with 1+ or 2+ and FISH negative disease. And when we look at our patient population, we see that our classically HER2 positive patients are about 15%, as we talked about. But this HER2 low group is a much bigger group of patients. It comprises patients who have triple negative or HR positive breast cancer, but continue to have HER2 1+ or 2+ with FISH negative disease. And then our completely HER2 negative or HER2 0 patients are approximately 30 to 40%. So if we think about HER2 directed therapies in this group, we have significant room to sort of change our treatment paradigm in the management of breast cancer. So we've started to see some early data in this space. So DAISY was a study that looked at T-DXd for patients with advanced breast cancer, regardless of HER2 status. So this study included 3 cohorts. It included patients who were HER2 0 by IHC, so completely HER2 negative. It included patients who were HER2 low, so 2+ or 1+ with FISH negative, and then it included our classically HER2 positive patients as well. Patients had to have received at least 1 chemotherapy regimen in the metastatic setting. I'm sorry, we have some fellowship interviews going on today. And they had central assessment of HER2 status. Primary endpoint here was confirmed best overall response. So here's the results from the DAISY study. And what we see, as we expect in cohort 1, is a very high response rate, greater than 70%. But what's more interesting is these other 2 cohorts. So looking at cohort 2, these are our HER2 low patients. We saw a response rate approaching 40%. And here are the waterfall plots for the triple negative patients, as well as the HR positive patients. And we see in both groups a response rate approaching 40%. So very interesting data. And what's really sort of intriguing is the HER2 negative. So these are complete HER2 0 expressors. And despite that, we see a response rate of about approximately 30% here. It did not meet the pre-specified endpoint to call this a successful cohort, but still, despite that, we see clear responses in both triple negative and HR positive patients, and a higher number of responses in our triple negative patients. So very intriguing data in the HER2 0 group. So just to summarize from the DAISY, we see that in the HER2 overexpressed group, we have really an established benefit. In the HER2 low group, there's encouraging efficacy with larger studies ongoing, and the HER2 non-detected group is intriguing data. And why might this group respond at all to HER2-directed therapies is somewhat explained by the fact that over time, our HER2 status in tumors can change, with the number of HER2-0 primary breast cancer patients becoming HER2 low over time across studies, and that might be why we see sort of this potential response in these patients. And so based on this, the Destiny Breast 04 study looked at T-DXd in patients with HER2 low disease who had received 1 to 2 prior lines of chemotherapy or prior progression on endocrine therapy, and patients were randomized to receive T-DXd or chemotherapy of physician's choice with primary endpoint of median progression-free survival. We've seen a press release now that this study was positive, and this study will be one of the plenary sessions at the upcoming ASCO in June. And so we await this data to see if it will really change the management of our patients with HER2 low disease. And then another sort of important piece with ADCs and growing piece is that of their role in the management of CNS disease. So no talk in HER2 positive metastatic breast cancer is complete without talking about CNS disease. As we follow patients with HER2 positive metastatic breast cancer over time, we see that they have sort of a constant and unabating risk for the development of CNS disease over time. So this is patients on day 0 who are first diagnosed with metastatic HER2 positive breast cancer, and we can see with each monthly follow-up that there's an increasing number of patients who develop CNS disease over time. So there's this constant risk that they will develop CNS disease. The first data that we saw that antibody drug conjugates may have some benefit in the management of CNS disease came from the Camilla study. This was a phase 3b study of patients treated with TDM1. And it included patients who had asymptomatic, untreated brain metastases, as well as patients who had previously treated and stable brain metastases. And when we look at those with CNS disease at the time of study entry, we see that clearly there is a response in the CNS disease of these patients, the best overall response, about 21% with TDM1. But what's more interesting is looking at those patients who had previously untreated disease, and the response rate approaches approximately 50% in the CNS lesions for those patients. So some efficacy with TDM1. And so that certainly makes us think about T-DXd with its increased potency. Does that have any benefit in the management of brain metastases? And so we have growing data that suggests that it does. So looking at Destiny Breast 03 study, when we look at the patients who had, in this study, remember patients could enroll if they had stable brain metastases. But looking at those stable brain metastases, looking at the subset of patients who did have brain metastases, we see that the benefit of T-DXd is still statistically significant and in line with our other subsets, suggesting that it really does have some efficacy in the control of the CNS disease in these patients. And looking at taking a closer look at those patients with stable brain metastases, we see that T-DXd compared to TDM1 did improve the median progression-free survival in those patients as well, with a hazard ratio similar to that of the overall study population, 0.25. And looking specifically at CNS responses in those patients treated with T-DXd, we see that a number of patients, the CNS lesions actually have complete response. 30% of patients, an additional 36.1% have partial response. So definitely very impressive CNS response rates in these stable treated brain metastases in the Destiny Breast 03 study. But of course, what's really on our minds is how do patients with untreated progressive CNS disease respond to these agents? So now we have some small data sets looking at this question. So Tuxedo 1 was a study that looked at T-DXd in patients with untreated or progressing CNS disease. Primary endpoint was clinical benefit rate. I'm sorry, primary endpoint was a response rate in the CNS, and secondary endpoints included clinical benefit rate. And looking at the primary endpoint of CNS response, just reported at ESMO Breast a few weeks ago, we see over 70% of patients had CNS response, including one patient with dural metastases, for a total response rate of 78.6%. So very exciting data for patients with untreated brain metastases. The overall number of patients in the study is small, only 14 patients. And so we certainly need bigger data sets. DEBRA was another study that was presented at San Antonio Breast last year. This was a study that looked at TDXD in patients with HER2 positive or HER2 low advanced breast cancer. And we want to talk specifically here about cohort 3, which was a cohort that enrolled patients with progressive brain metastases that had previously been treated. So these are heavily pretreated patients who have received prior CNS-directed therapy. You can see the majority of patients had received at least 5 lines of systemic therapy, and all patients had had some kind of CNS-directed therapy. And despite that, we see response in the CNS disease of these patients with a partial response rate over 40%. So again, small numbers, but very encouraging data that TDXD has some efficacy in the management of untreated and progressive brain disease. And based on this, there are several studies now ongoing looking at not just TDXD in patients with active brain metastases, but what I also want to highlight is several studies ongoing looking at the combination of antibody drug conjugates and TKIs in patients with active brain metastases. And it'd be really interesting to see the efficacy of this combination in the management of CNS disease, to see if we can really make an impact for CNS disease for our patients. And one last thing I want to comment on before we depart is that of the combination of antibody drug conjugates and immune checkpoint inhibition. As TDXD grows in both the HER2 positive, but also in the HER2 low space, one question that is definitely to come up is, can we combine it with IO agents and increase that response? And so we've seen some early studies now looking at TDXD and IO combinations. So just presented a few weeks ago at ESMO Breast, we saw a combination of TDXD and nivolumab in HER2 positive patients, median of 5 lines of prior therapy, and very impressive response rate of 66% in these patients. And at ASCO last year, we saw data on the combination of TDXD and durvalumab in HER2 low frontline metastatic breast cancer. And here we saw, again, very impressive responses with a confirmed response rate of 67%. What these studies don't answer, though, because of their lack of randomization, is this data with combination with IO better than TDXD alone? And of course, we need larger randomized data to really answer that question, but certainly studies that we'll see in the future. So with that, I will wrap up. So my take-home points from today include the prognosis of HER2 positive breast cancer has dramatically improved with the development of novel HER2 therapies. As we saw from Destiny Breast 03, TDXD significantly improved median progression-free survival compared to TDM1 in the second-line setting. Overall survival here is pending. The combination of tucatinib, trastuzumab, and capecitabine is efficacious in the management of patients with untreated and progressive CNS disease. But there is a growing indication for HER2 antibody drug conjugates, particularly TDXD, in the management of HER2 positive breast cancer brain metastases. And beyond HER2 positive disease, there's also growing indication for HER2 antibody drug conjugates in HER2 low breast cancer, as we excitedly await the data of Destiny Breast 04 at ASCO. And this will very drastically change our current paradigm for breast cancer management. So I will stop there and open it up for any questions.
Thank you